So hello everyone, thank you for joining us today. My name is Naomi Line and I'm the Education Manager at Prostate Cancer UK. Before introducing our speaker, I just wanted to remind you that throughout the session, we will be monitoring the Q&A chat, so please do post any questions there and these will be addressed at the end. So it's now my pleasure to introduce our much valued speaker, Dr Samuel Merriel, who is a GP in North West England and NIHR academic clinical lecturer at the Centre of Primary Care and Health Services Research at the University of Manchester. Dr Merriel also contributes to medical literature and is an associate editor for the British Journal of General Practice, BJGP. His main research interests are the early detection and prevention of cancer in primary care and the evaluation and implementation of new diagnostic tests. Sam has conducted research into prostate cancer diagnosis in primary care, including the role of symptoms, the accuracy of PSA, and the potential impact of prostate MRI. Sam served on the NICE Prostate Cancer Guidelines Update Committee in 2021 and has been a member of expert reference groups for Prostate Cancer UK, Movember, NHS England and the National Cancer Research Institute. So without further ado, I'll hand over to you, Sam.
Thanks very much, Naomi. Good afternoon, everyone. Thank you so much for joining this talk and for having me along. It's very sunny here in Manchester and hopefully wherever you are joining this webinar, the sun is also shining for you as well. Naomi, can I just double check that those slides are showing up and it's the title slide?
Yes, all working, Sam. Thank you.
Fantastic. Yeah, and then thank you again for that very kind introduction, Naomi. Yeah, so I guess this talk, so the content for this talk, I'm aiming to sort of only talk for sort of 30, 35 minutes really, just to sort of bring the latest updates and things on the state of play with prostate cancer and try and make this as relevant as we can to practicing in Scotland, which is where I gather you're all joining from, just so we can leave some time for questions. So can I echo Naomi's suggestion? If you've got any questions or any things you wanted to raise, please do put them in the Q&A section and we'll try and get to them at the end and make sure we've got time for that. So the main things we want to get through with this seminar are sort of covering the following topics. So looking at the main risk factors to think about when you're assessing a person's risk for prostate cancer, looking at the question of PSA testing, when is it indicated, when will it help with prostate cancer detection and how to use it. Talk about the recent changes in the diagnostic pathway, which is really, really important for colleagues in primary care to be aware of, because it does fit into our conversations with men about testing and what happens next. We want to touch on the sort of persistent inequalities that exist with prostate cancer and things for us to keep in mind and what we might be able to do about it, and sort of give you some resources and places to go to get more information and support for your conversations with men around prostate cancer. So just looking at the situation, and this is data from England, but it reflects the situation in the UK as a whole. So we are seeing over 50,000 new diagnoses of prostate cancer each year. And that figure is actually expected to rise quite significantly. So the recent Lancet Commission on Prostate Cancer, which published their report last year, estimate that by 2040 in the UK we'll be seeing 80,000 new diagnoses of prostate cancer each year, which is largely being driven by demographic changes, but it's going to be a growing issue in the years to come. And even though a lot of men live with their prostate cancer rather than die from it, the sheer numbers of men with the disease mean that it is a big killer in terms of cancer-related mortality, and it causes over 12,000 deaths every year. There's no current sort of formal screening program for prostate cancer in the UK, and that obviously has been considered by the UK National Screening Committee and the sort of devolved administrations of the four members of the UK over the years, and at the moment there's no sort of national commissioned prostate cancer screening program. And as I mentioned, it's becoming more common and it has become more prevalent than breast cancer. And some of the recent interventions by celebrities and sort of well-known figures who've come forward about their diagnoses of prostate cancer has kind of driven a lot of interest in the area and a lot of awareness. So obviously Sir Chris Hoy going public with his diagnosis late last year has seen a sort of an increase in interest in this subject, and a lot of people coming forward to have those conversations. And some of the data, which we're going to talk more about later on from the National Prostate Cancer Audit, has shown there's sort of more men undergoing treatment in recent years as a result. Thankfully, in the UK, I guess partly because of the way the NHS runs, but also the way that the NPCA audits urology departments on their treatments for men, the risk of over-treatment in the UK is relatively low compared to other countries. So we're seeing fewer men with low-grade prostate cancer undergoing radical treatment, things like surgery and radiotherapy, when they could be on active monitoring or active surveillance compared to other countries. Zeroing in on Scotland, so the latest data suggests that over 4,300 men are diagnosed each year, and around about 1,000 men die each year annually from prostate cancer. It is the most common cancer in men, although not the most common cancer overall for the Scottish population, and there's quite a large number of men living with it. The graph here on the right sort of talks about treatment, and I think there's two things to take away from that. One is this sort of dramatic drop when the pandemic hit below sort of long-term trends in terms of men being treated, which we see for all cancer types. But the really key issue with prostate cancer coming out of the COVID pandemic was that it was the slowest cancer to recover in terms of expected diagnoses. So Prostate Cancer UK and the NHS got together to do some awareness raising campaigns to try and get men coming forward or being aware of things to look out for to try and address that slow recovery. And that has sort of gradually happened, but now we're sort of back on the longer term trends of more and more people being diagnosed and treated. So I mentioned the National Prostate Cancer Audit. So this is an annual report that is released, led by the Royal College of Surgeons, and it does audit all urology departments across England and Wales, and looks at their diagnoses, their treatment data, and sort of what outcomes men are having from their prostate cancer journeys. And it's given some really interesting insights. So the report came out late last year again, and it showed an increase in diagnoses across the board in England and Wales, and separately, Prostate Cancer UK have sort of shown there has been a rise in recent years of diagnoses in Scotland. In terms of treatments, as mentioned on the previous slide, we're seeing more men being treated for the disease, which, whether that's relating to more advanced disease presenting because of the interruption of the pandemic or just a sort of demographic shift with older men being more likely to get diagnosed, is sort of still playing out at the moment. Over-treatment, again, as I said before, it's not as big a problem in this country as other countries, but it is still happening. And treatments still have their complications in terms of genitourinary and gastrointestinal problems. It was highlighted in the most recent report about some of the challenges that Black men with prostate cancer face, and both in terms of the likelihood of late-stage diagnoses as well as getting guideline-recommended treatment. And there was some data from the NPCA to suggest that they were more likely to be diagnosed with late-stage prostate cancer when took other things into account, and also less likely to have guideline-recommended treatment in a prompt fashion. So that there are some persistent issues there that obviously need to be addressed. And sort of, going on with that sort of theme around inequalities. So we know that Black men have about twice the risk of prostate cancer compared with men of other ethnic origin. So compared to white men, men from Asian backgrounds actually have less likelihood than white men to get prostate cancer, but it still happens, importantly. And Black men are also more likely to die from prostate cancer. And there's some evidence about they're at high risk at a younger age. So, we're seeing more Black men in their sort of 40s and early 50s with advanced stage disease compared to other ethnic groups. In terms of other drivers of inequality when it comes to prostate cancer, so we know that rates of metastatic disease at diagnoses are associated with deprivation. So, men from deprived areas, from coastal regions, from rural regions are more likely to be diagnosed with late-stage disease. And it's sort of important for us to keep in mind when we serve different populations in primary care. And there's quite significant geographic inequality. There's almost this kind of gradient. The further north you go in the UK, the higher the rates of metastatic disease at diagnosis. And there's probably a number of factors at play there. So that's the kind of broad overall picture of where we're up to with prostate cancer at this point. In terms of your risk, so for GPs or GP trainees in your practice, seeing men, in terms of when you're trying to talk to men about their risk and trying to assess yourself, what is the level of risk? It's relatively straightforward. There's only a few sort of well-established key risk factors to think about. So the first thing is family history. So relatively simple question to ask patients, do you have a family history of prostate cancer? And if they have a first-degree relative of prostate cancer, so a father affected or a brother or a son, that at least doubles their risk of developing prostate cancer themselves. And it can mean they're more likely to develop at a younger age. Family history is also key because there's growing evidence about the role of specific mutations that put men at higher risk of prostate cancer. And the most common one with the most evidence is around the BRCA gene, and particularly BRCA2. So if there's a known person in the family with a BRCA2 variant, or if the man's happened to have a test, and they know their BRCA status and they've got a BRCA2 mutation, they are at increased risk as well. Another way to kind of get a hint for that is if you're asking more in-depth family history and asking about other BRCA-associated cancers. So if they've got lots of relatives with breast cancer or ovarian cancer, that should be raising your suspicions about whether there's some kind of genetic component, and does that affect this man's risk of developing prostate cancer. And as we mentioned earlier, black men have twice the likelihood of developing prostate cancer compared to white men, and about 1 in 4 black men in the UK will develop prostate cancer in their lifetime. So the other common thing we see in primary care is men presenting with lower urinary tract symptoms. And there's a lot of debate about how relevant they are in terms of early detection of prostate cancer. The often sort of used phrase that early stage prostate cancer has no symptoms is trotted out, but the evidence behind that in terms of relevance to primary care is pretty weak. So a lot of the studies that those assumptions are based on are either subcohorts of screening trials, or they're small secondary care routine outpatient cohorts. There's much less primary care evidence, but the primary care evidence that does exist suggests that there is potentially an association. So this is data from the 2014 National Cancer Diagnosis Audit, and it has been replicated in the 2018 audit. And this looked at all men in the audit with prostate cancer. So for 2014, that was over 1,100 men who presented, who were diagnosed with prostate cancer, and looking back at their record, they had presented with lower urinary tract symptoms in primary care in the lead up to their diagnosis. And when we looked at stage at diagnosis, so 60% were diagnosed early stage disease, and less than 1 in 5 had stage 4 disease at presentation. So not all men with prostate cancer will exhibit symptoms, but there is a window of opportunity potentially for some men with symptoms to be diagnosed at an early stage. So it's important to keep that in mind. In terms of current guidelines, so the current guidelines do talk about considering investigating men with symptoms, and obviously the other things to think about with symptoms is the age of the person. There are other medical comorbidities, because obviously lower urinary tract symptoms get more common in older men, but that's the current state of play. There's currently no sort of specific guidelines for the Scottish population around PSA testing in asymptomatic situations, although it is important to highlight that all the sort of current cancer referral guidelines for Scotland are under review, and the updated version is expected to be published later this year. So, whilst it's worth being across the current guidelines, it's also worth being aware that things might change later this year. So they're going to be published, as we mentioned. There may be some sort of now guidance coming in around PSA testing for asymptomatic individuals. So in England, there's something called the Prostate Cancer Risk Management Program, which says that men over 50 can come and talk to their GP about getting PSA testing as a screening test. And talks about the pros and cons of that, and has some patient information and resources around making those decisions. And there is a program at NHS England called Getting It Right First, Getting It Right First Time, or GIRFT, and they published a sort of a national guideline on sort of the ideal prostate cancer diagnostic pathway, which did have some primary care input and did have some relevant recommendations for primary care in terms of PSA testing, in terms of when it's useful to do an examination, things like that. So those resources are potentially worth your while, but I guess this is kind of an evolving space, so watch this space. So in terms of if a patient's been counselled on PSA, or they've been suggested to have a PSA test, in terms of who can sort of have those conversations. So the guidance from Prostate Cancer UK suggests that it doesn't just have to be a GP. If there's someone who's suitably experienced and trained and understands the pros and cons of PSA testing and can answer men's questions about that, then it could be another member of the team. And another thing to emphasize in terms of primary care assessment is the role of examination. So in a screening context, DRE doesn't perform well as a screening test for prostate cancer. and a normal feeling prostate on examination does not rule out prostate cancer. So, and if you've got a patient who's got an elevated PSA, then even if their DRE is normal because you can't palpate most tumors, that shouldn't be a reassuring thing, and the referral decision should be based on the PSA level, possible explanations for it, and the man's level of risk. So just sort of zeroing in on the blood test a bit. So it can be useful for detecting prostate cancer at an early stage. Whether that makes a significant difference to a patient's long-term outcomes is, it varies depending on the trials you look at. But it can pick it up at an early stage where treatment can potentially sort of improve or extend life. And repeat PSA tests. So even the guidance in England doesn't give any guidance for GPs around how often PSA testing should be done or when it should be stopped. But there is some good evidence to say that sort of changes in PSA over time can sometimes give you a more indicator of whether something's changed there. And if there's a significant change from the baseline that's not explained, then that could potentially be quite useful in terms of your clinical assessment. So other things to emphasize, so PSA is not tumor specific, so it's a normal substance made by the prostate. It's normally found in the blood to some degree for all men. So it doesn't, just because it's elevated doesn't mean they definitely have prostate cancer. It can go up for other reasons, so recent infection, recent urological procedures, very large prostates can all push the PSA levels up. And just because a PSA level is elevated, that doesn't give you a very strong indication of whether this is clearly a clinically significant cancer that warrants treatment, or whether it's a low-grade clinically insignificant cancer that might otherwise not have affected the man. There are also treatments that can push PSA down. So I guess if you've seen a patient and they're high risk and there's a concern about prostate cancer, but their PSA level is kind of borderline, there are certain medications like the 5-alpha reductase inhibitors, some of the treatments for balding, some diuretics that can actually push PSA levels lower. And we're actually finding men who are overweight tend to have slightly lower PSA levels. So I guess the key things are if there's a clinical concern about prostate cancer and the PSA is kind of a bit ambivalent as to whether you need to refer or not, or it doesn't quite meet the threshold, but the concern is high, there's a couple of situations. And one thing is to just plan to repeat the test, give it a few weeks, see if there's a trend or a change over time, or seek advice from your local urology colleagues. So in England, the guidance around asymptomatic testing suggests that men over 50 can come and ask for tests, but it has been highlighted by a number of groups, including Prostate Cancer UK, that men in their 40s who are high risk can potentially develop prostate cancer as well. Obviously, the Chris Hoy situation, he was diagnosed in his late 40s. We know there's evidence that black men develop prostate cancer at a younger age. So there is some suggestion that, men who are high risk should think about PSA testing from mid-40s onwards. If you want to access Prostate Cancer UK's latest statement on asymptomatic PSA testing, you can use this QR code on the screen. We also have links to the documents and other slides in this slideshow, so you hopefully can access that if you're interested. Oh, there you go. We've got it on the website as well. So that's the kind of primary care side of things. So now we're sort of moving on to talk about what's happening in secondary care and how is that affecting the potential benefits and harms from testing. So go back 5 years, 6 years, the standard diagnostic pathway was men would get a PSA test, and then the next test they would undergo is a transrectal ultrasound-guided biopsy. Now, so trust biopsy, so it's the specialist would use the ultrasound to locate the prostate, but it can't actually tell you whether one part of the prostate looks abnormal or not. So they were just using the ultrasound probe to find the prostate, and then trust biopsies were essentially random samples. So just take a sample from different parts of the prostate. Now, prostate cancer is often multifocal, so there's different deposits of prostate cancer in different parts of the prostate, and they can often be of different grades. So with a trust biopsy, they might have just randomly picked up a low-grade tumor on the left side of the prostate and then missed the high-grade tumor on the right side. So that patient will be diagnosed with a low-grade prostate cancer, but actually the high-grade tumor has been missed. And then if they were put on surveillance, sometime down the line, their prostate cancer is going to progress. Trust biopsy also, because it had to go through the rectum, there's risks of infection, there's risks of bleeding, and the sepsis rate for trust biopsy was about 1%. So that's kind of where the paradigm was, and all the screening trials looking at sort of PSA testing followed by diagnostic testing with the sort of long-term follow-up are all in that kind of pre-MRI era. So the current evidence around the pros and cons of PSA screening are in that context, and the diagnostic pathway has now changed. So that evidence is largely becoming more and more out of date as time goes on. The change to guidance has now resulted in sort of what's called pre-biopsy MRI as an approach. So certainly the standard in England, and I believe it's being rolled out in Scotland as well, is that any man who's referred with suspected prostate cancer should be offered what's called a multi-parametric MRI first. And multi-parametric just means that they've taken multiple different views of the prostate using different MRI techniques. And the radiologist will put that together and they boil it down to a score out of 5. It's called the PIRAD score. So a score of 1 says the radiologist feels this prostate looks completely normal. There's no sign of anything abnormal here. Through to 5 being this prostate looks really nasty. I'm really fairly confident there's cancer there somewhere. And the current guidelines say if a MRI is reported as being normal in terms of the prostate, so a PIRAD score of 1 or 2, almost all those men will be discharged without a biopsy. So that's the first benefit of MRI, is that we're now seeing, certainly in England, a quarter to a third of men referred from primary care, at least, depending on the centre, having their MRI, it's looking normal, and they're being discharged back to primary care. And the trials show that MRI is very good at detecting clinically significant cancer without making overdiagnosis worse. If anything, the small low-grade tumours don't tend to show up in MRI as much as the significant cancers do. And the negative predictive value of a pre-biopsy MRI for prostate cancer is about 90%. So 9 in 10 men with a negative MRI won't have prostate cancer. So it's not a perfect test, but it's quite a good test as a second-line triage test. The other advantage of an MRI is you now have very detailed images of the prostate, which the specialist will then use to guide their biopsies. So often they're now MRI guided, so they'll take the images on the screen. They'll say, okay, in the right side of the prostate, near the anterior point, there's something that looks a bit abnormal there. That's where I'm going to target my biopsy. And now, so the trials of MRI followed by targeted biopsy have also shown that the biopsy yield is better. So they're more often getting higher grade tumours out of their biopsies. They're needing to take fewer samples from the man because they don't have to just sample the prostate at random. And the likelihood of missing a significant cancer with that MRI first guided biopsy approach is less. The other thing that's changed about biopsy in secondary care is the approach. So whereas it used to be a transrectal ultrasound guided biopsy, now the recommendation is transperineal. And there was a big trial comparing the two approaches that just presented its results at the European Association of Urology meeting just the other week. And there's pros and cons. So it's a more accurate test. They can access all areas of the prostate. So with trust biopsy, it was tricky to access some parts of the prostate. For transperineal, they can access more parts of the prostate. The risk of infection is much lower, and it can be done these days under local anesthetic, so doesn't require a GA or anything like that. There are some trade-offs though. Men do report that it's more painful, and the risk of some of the other side effects from biopsy, like urinary retention or hematuria in the short term, are similar. So overall, it's a better test with some trade-offs. But that's the kind of how the diagnostic pathway has changed. So when we in primary care are having conversations with men about do they want to go forward for prostate cancer testing or not, the old kind of system of just going straight to trust biopsy is becoming outdated pretty quickly and is no longer the standard of care. So that kind of shifts that risk of harms from investigation and overdiagnosis, and it might sort of play into how those decisions are made. So that's really important for us in primary care to be aware of. So just to kind of summarize that, so, previously before, the other issue with PSA was that, the majority of men with elevated PSA don't have prostate cancer. So not only were we sort of putting men at risk of harm from these biopsies, but we're also sending a lot of men for these tests because PSA is not particularly specific when it comes to prostate cancer. And because of the random sampling nature of trust, it was the diagnostic accuracy was lower. Whereas now, we can prevent 1 in 3 to 1 in 4 men from even having a biopsy in the first place. Overdiagnosis is the same, if not less. And, the sepsis risk is much lower now that transperineal is the standard approach. And the evidence for that is growing all the time. So the team at Prostate Cancer UK did some sort of basic modelling around sort of what would happen in the old pathway to 10,000 men having a PSA test, and then what would happen in the new pathway. So this is kind of the model of the old pathway in terms of, if 10,000 men had the test, about 1,600 would have an elevated PSA. Most of them would go for biopsy. Some would have sepsis. Some would be diagnosed, some wouldn't. And then when they compared the pre-MRI era kind of standard pathway to the modern pathway, the modelling evidence shows, and some of this is being borne out with real-world evidence that's starting to come out, is that the risk of sepsis is much lower. The likelihood of having a biopsy is much lower, and the likelihood of having a biopsy where there's no cancer found is also lower. So there's fewer unnecessary biopsies being done with this MRI first approach. So, this is potentially a really significant reduction in harm from the diagnostic pathway for prostate cancer. This is kind of summarizing that in the figures in the model in the first two columns, and then some of the early real-world evidence. So from what's called the RAPID pathway, which is one of the NHS trusts in London and the southwest of England, have sort of tracked their data around post-biopsy sepsis, around number of negative biopsies, which is coming down because of the MRI first approach, and the number of overdiagnoses, which is also coming down. So we're starting to see the trial evidence being played out in sort of real world evidence as this is being rolled out, certainly across England. And then this is a summary of the harm again from the same kind of regions. So, the risk of, unnecessary biopsies are lower, risk of overdiagnosis is lower, and the risk of sepsis again is low, is reduced with the transperineal biopsy approach. So significant reductions in harm. And these are some of the figures that charities put out around it. These data are still coming out all the time, so these figures are constantly getting updated. So that's kind of explanation about the diagnostic pathway, and I'm very happy to talk about that in this sort of chat time. So in terms of resources that are available to you to sort of go through these conversations with men and then think about the pros and cons of PSA testing. So Prostate Cancer UK have a consultation toolkit that goes alongside their statement on asymptomatic testing. There are also other sort of CPD opportunities and other resources that are freely available for patients in your practice to use. So do use that QR code or pop onto the Prostate Cancer UK website if you're interested in any of those resources. There's a lot of patient-targeted health information, and Prostate Cancer UK do engage with a wide range of men, both those who've suffered from prostate cancer, but also just men in the community to inform their patient information, and a special plug to the specialist nurses. So the charity does employ a group of specialist nurses who are there on the end of the phone for advice for patients, members of the public, and clinicians. So if you as a GP or GP trainee have questions about prostate cancer detection, or want some further advice or want to talk through a case, please do pick up the phone and speak to these nurses. They are really dedicated. They're very expert. They've been doing this for a long time, and they're a really good service to have. So I would encourage you to take advantage of that if it helps your training or your care for your patients. Last plug before I finish. So some of you may have heard about something called the Transform trial. So this is a UK-wide prostate cancer screening trial that will start recruiting this year, and it's funded by Prostate Cancer UK and the National Institute for Health and Care Research through the Health Technology Assessment Program. And it's a really big, ambitious trial. The price tag's 42 million, and the charity is committed to funding at least 2/3 of that, and the government is going to chip in the rest. And it's going to be UK-wide. So it's going to recruit in Scotland, it's going to recruit in England, Northern Ireland, and Wales. And we are sort of taking some of these sort of latest developments in prostate cancer diagnostic technology and testing them out in a new approach to screening. So there will be PSA tests being used, there will be upfront MRIs being used, there will be genetic testing to inform risk stratification and screening. And this has been developed with some of the world leading experts in prostate cancer that we have here in the UK, alongside the UK National Screening Committee, to try and sort of answer that question in the modern era. What's the best way to screen for prostate cancer? Is there a way where the benefits clearly outweigh the harms that might be taken forward in the future? So I'd say look out for this. If it's recruiting in your area, we will obviously be working with primary care and secondary care to try and make sure we, make this accessible to all men and make this trial a success. But just watch this space basically for that. So key take-home points is to be aware that the Scottish Cancer Referral Guidelines are currently under review and that the updates are expected at some point this year. That certainly in England the diagnostic pathway has changed, and we're seeing these changes reflected in other high-income countries where MRI is coming in before biopsy, and that's reducing the level of harm that men are experiencing from the diagnostic pathway, which is then important for us to be aware of in primary care. And PSA step, but the PSA test is still the first step in that pathway. Obviously PSA hasn't changed since it was introduced into clinical practice decades ago. Is relatively cheap, relatively easy to organise, and interpreted carefully, can be quite helpful in terms of picking up prostate cancer for men at an early stage. And obviously the charity is very strong on and trying to make sure that men at high risk are aware of their risk. They can access help and advice when they need it, and hopefully we can improve outcomes for men and reduce inequalities in prostate cancer. And that's everything from me. So I'm going to stop sharing now. Thank you for listening. Very happy to take any questions.
Thank you so much, Sam. That was fantastic. There have been quite a few questions that are coming through in the Q&A, so thank you for that. And just to say, if you've got any questions whilst we're answering the other questions, please do put them in the Q&A and we will get to them as well. So I'm going to start with the first question, Sam, if that's okay. Elaine wants to know, as part of diagnosis, do men still get a DRE?
Yeah, so the role of DRE is a really important thing to think about. So as I mentioned in the talk, it does not have a role as a screening test for prostate cancer. So if a patient's got no symptoms, they're coming in talking about potential screening for prostate cancer. DRE has no role there. There's good evidence to say it's not very good as a screening test. For men with symptoms, it's potentially useful. So, clinically, you can get a feel for whether the patient has a very large prostate or not. If there's a question of prostatitis, that can also, your DRE can also help your assessment there. And then there's a question of if there's an abnormal feeling prostate, does that help us pick it up? So, as I said before, most prostate cancers you can't palpate or you can't feel at least until they're really advanced. But the existing evidence we do have suggests that if a primary care clinician examines a patient, feels abnormal, and they're referred, the risk of being diagnosed with prostate cancer is well above the kind of current risk thresholds used in Scotland or England. So in a symptomatic context, it might be helpful, but it's not very helpful as a screening test. And I think the only other thing to be very mindful of, and this is another thing the charity's done a lot of work with men around, is examination is a barrier to men coming forward, particularly men from certain groups. So there's still an expectation in the community that if you're going to go talk to your GP about anything to do with your prostate, you've got to drop your trousers. And I think we need to tackle that kind of assumption head on and try to make it clear that it's only used in certain circumstances. It only adds a certain amount of extra clinical benefit. And for a lot of men, they won't need it. And, even in secondary care, the urologists I work with and speak to, they very seldom do them anymore because of things like MRI that have come along. So having said all that, I'm aware that in certain regions of the UK, it's still a requirement for referral, which I think needs to be challenged because I don't think it should be done in all settings. But yeah, in symptomatic patients where you're worried or the PSA test normal, but you're still worried, it potentially has a role.
Brilliant. Thank you so much. And that's certainly something that we're hearing around men being worried about a potential DRE and really pushing, the PSA blood test being the first test to kind of get that, get things moving really if they need to. Brilliant. There's a few more questions that have come in. So the next question is, when did you say 80k diagnoses predicted per year? Do you believe incidence has gone up, or are there just more men being diagnosed?
Yeah, so the Lancet Commission expects by 2040, so 15 years from now, they're expecting 80,000 new diagnoses of prostate cancer in the UK every year. So it's quite a big jump that's coming. And the other point they made is that we haven't identified anything that you can do to prevent prostate cancer. There's no kind of interventions at a public health level or a patient level that significantly lowers a man's risk of prostate cancer. So they're kind of coming. And the point the commission made was the focus needs to be on getting the diagnostics right. So getting MRI implemented, getting the pathways consistent and equitable, and trying to improve treatments, because this is kind of coming and we've got to be able to deal with it. The second bit about is that just more men being diagnosed. I think the rate of increase is more than just increased awareness. Obviously we've got these big demographic shifts. We've got the baby boomer generation who are all reaching kind of retirement age, and they're all going to get into their 60s, 70s, and 80s in the coming years. So I think that's the bigger part of it, and just that generally, Western societies are getting older as a general population, and it's not just a UK trend; it's a global trend. And actually, the rate of increase in the UK is smaller than in Africa and Asia. So, there the increase in prostate cancer diagnoses is expected to be 100% or more. It's going to more than double in Africa. It's going to almost double in China. So there's big jumps coming globally, and the UK is not immune from that.
Brilliant, thank you. That's really helpful. I've got a question from Luke here. Thank you, Luke. He says, thanks for a great talk. He's got two parts to the question. Number one, you mentioned there were factors which increase the chance of people living further north presenting with metastases, and what are they? And two, you mentioned that potentially if monitoring PSA, a significant change from baseline may indicate early cancer. Can you quantify?
Yeah, thank you, Luke. Great question. So the first question, so the reasons why higher rates of metastatic disease at diagnosis in the north, in further north you go, I don't think that's fully understood. There's a lot of work going on, and certainly some of my own research is trying to unpick that. It's probably partly an awareness thing. It's probably partly an access to PSA testing thing. It's probably linked to deprivation as well, because places where I work and obviously places further north, there are more deprived communities relative to southern parts of England. So I think there's a lot of factors at play there, and I would love to give you a firm answer, and maybe I'll come back in 5 years when I've done the research and tell you. The second question, so monitoring PSA. Yeah, so if a patient decides they're going to go ahead and have a PSA, or you've got a baseline test in their record from some time in the past, what's a significant change? That's a really good question. I don't think there's a firm answer on it. There are a couple of things. So certainly for patients who've been diagnosed, treated, and discharged, the urologist will also often talk about a PSA doubling time. Now that's often when patients have treated, their PSA is very low, so it doesn't take a big shift to double. But if the PSA doubles within, say, a year or two, that can potentially signify a significant shift. Certainly, if you saw a patient that had a PSA of, say, 2 or something, and it was done 12 months ago and now it's 4, that would potentially raise some alarm bells. And I guess whilst regular PSA testing is hard to give clear guidance on exactly how often men might want to have a regular test, and again that depends on their risk. If you've got a series of PSAs and then suddenly there's a big uptick, that can sort of suggest that something's going on. So in terms of how often people get tested, so there is no guidance in the UK about how often a man should be tested. That should be sort of thought about on an individual risk basis. But in Europe, the current European Association of Urology guidelines, again, it depends on age and family history. So if they're in their 50s, they'll get repeat tests every sort of 2 to 4 years, depending on their level of risk. Men in their 60s, if they've got a PSA kind of below the referral threshold, they can wait up to 5 years before they need another test. Yeah, I'd say in terms of what's a significant change, so, I think if you're seeing double, that should be raising red flags. If it's kind of creeping up over time, that may be just an age-related thing. But each time you see a change in the PSA level, if you do see a change from the baseline, think about what else could be causing it. Make sure you rule out infection. Make sure they don't have any recent procedures. And if you're ever in doubt, just sort of repeat PSA and see what the trend is.
Brilliant, thank you. I'm going to take you on to our next question then. The question is the MP-MRI provided at most secondary care trusts, or is this only available at specialist tertiary centres?
Yeah, really good question. I can't specifically comment for Scotland. I honestly don't know. I think the last time I spoke to him about it, It's not available everywhere yet. It's pretty widely available in England now. It's not just specialist centres, but there is a level of training for radiologists and radiographers to get good quality MRI. So the specialist centres are probably doing this really well. In centres where they're still just bringing it in, or if it's a district general hospital or something, it might be that the MRI quality is a bit more variable or a bit lower. So it's becoming the standard of care, not just in England and the UK, Australia, North America. It's coming in a lot more. But yeah, I don't think it's 100% coverage yet.
Brilliant, thank you. And just the second part of that question, or I guess another question within that, in terms of the north-south divide, would you say there's more capacity to provide NP-MRIs in the south, and as a result, could this potentially be contributing to geographical inequity? It's a great question.
Good question. So I think the first question is yes, probably there is probably more MRI capacity in the south, just because the systems here have potentially less resources and less access to sort of private care and stuff. But I seriously doubt it's a driver for the north-south differences, because that's been pretty well established for some time before MRIs become standard of care. So I don't think that's a major factor. It might be contributing a bit, but I think that's a relatively minor factor.
Brilliant, thank you. And another question we have is, what are the modifiable factors that men at risk, for example, due to ethnicity or family history, can do to reduce their risk?
Yeah, so it's tricky because there's not a lot with really good evidence behind it. There's been a lot of work looking at diabetes and a sort of metabolic syndrome and how that impacts on prostate cancer risk. And there's some suggestion that sort of having healthier lifestyle, lower HbA1c and things like that can impact on your risk. There was some trials around, I can't remember the substance, but something that's very high present in high quantities in tomatoes, but I can't remember the name of the substance now. There were some theories around diet and reducing the risk of prostate cancer. But again, when they were actually trialed in proper studies, that didn't really show a lot of evidence that it helped reduce the risk. So still a work in progress to find those things that can reduce risk and prevent prostate cancer. But I think the main thing we can do for men now is lycopene. That's it. Thank you, Shaim. That was the word I was looking for. The main thing we can do for now is talk to men about the key risk factors and having an awareness, because some people don't even know their family history, so that starting those conversations to sort of find out might be really useful as a starting point.
Brilliant, thank you. And like you said, those risk factors can really make a difference in terms of people not being aware of their family history and that risk, and having those conversations to start that up, and also potentially looking at your records as well and seeing if you can capture that at all, kind of moving forward. Brilliant. I've got another question for you, Sam. Has the guidelines for management of prostate cancer and advanced prostate cancer changed?
In terms of management, it's less of my forte, but I think the short answer is yes. So in recent decades, one of the reasons that prostate cancer outcomes have improved is mainly down to treatment. Before MRI came in as a new diagnostic test, a lot of the advances were new treatments coming on board. So in terms of sort of immunotherapies and some chemotherapies that have better evidence for them. Tricky things with these treatments is they're very expensive, and they don't tend to be curative. They tend to kind of hold prostate cancer at bay, but you do have men with metastatic disease on systemic therapies that need it for a long time. And sort of it gives them a lot more years, but their quality of life can still suffer a bit, and they struggle to get off it. So we've had a case that's made the news in BBC in England about there's a certain treatment that NICE won't commission that can be quite effective, that men are having to access privately. So that's an ongoing thing in terms of treatment, and the way that prognosis is determined has also evolved recently. So it's more nuanced about who's got a low risk cancer, who's got a high risk cancer, and what do we do with the men in the middle.
Brilliant, thank you. Our next question for you then is, when do you think Scottish guidelines and those in England will change to reflect the risk we are seeing in asymptomatic men, and how easy is it to get these guidelines to change? I imagine it would be a rigorous process.
Yes, I imagine so too. And again, I profess my ignorance of the Scottish guidelines groups in Scotland, but certainly my own work with NICE, and the UK National Screening Committee, the bar is very high. Obviously, they're making decisions that apply to the whole population. From that point on, you've got to commission a program that's equitable, that can be accessible to all people, and not put others at advantage or disadvantage. And it has significant resource implications for the government and the health service that commission it. So, yes, the bar is very high. I honestly don't know where things will go with Scotland. My understanding is that all four nations of the UK tend to follow what the UK National Screening Committee recommend, even though the NSC is technically for England and Wales. So I guess that will give a big steer as to how things go going forward. So, hopefully if Transform goes well and we find a way that clearly benefits men with low risk of harm, maybe that'll come one day, but it is a long process.
Yeah, that is definitely something that we're finding, isn't it, Sam? The next question for you then is there any data about the risks in trans men or trans women?
Yeah, brilliant question. And it is something that has come up at various meetings in recent years. And the answer is the data is pretty, thin on the ground. We honestly don't know a lot about it. And obviously it's a very nuanced and sometimes complicated situation depending on treatments people have undergone in terms of transitioning. Are they on ongoing treatments? And not just prostate cancer, but all types of cancer screening. What do you do about breast and cervical screening for trans men, and all that kind of stuff. So it's a really important question, a really important area, and I think we're still learning is the honest answer. But hopefully we'll have some better data and understanding in the future.
Thank you. And just on that as well, on our new online learning platform, we do actually have a module on trans women and prostate cancer as well. So do go and check that out if you feel it would be useful. And I think it's just like Sam said, being aware that if you have someone who is transitioning who comes to your GP practice, that they are still at risk of, the various cancers, prostate cancer, breast cancer, cervical cancer. So thank you, Sam. There's a question, I've just lost it. Will there be recording of this session? Yes, so we're recording this session and this will also be on our online learning platform on webinars as well. So do share with colleagues and it also gives you an opportunity to go back and have a look if you've missed anything today. I'm just going to give another opportunity for questions, but Sam, I'm just going to ask you a question from me if that's okay. How do you feel that your own practice has changed over time with regards to the PSA blood test and changes to the diagnostic pathway?
Well, I'll confess, I've only been qualified as a GP for 5 years, so it hasn't been that long. But I guess the more I've learned about MRI and the diagnostic pathway and how things are playing out, I think I'm probably less hesitant about PSA testing than some of my senior colleagues who've been around in the previous years of PSA-based screening trials and things. I still, I have personal research interest in identifying the high-risk men that come to primary care, and the role of symptoms and things like that. So, still trying to work out, what's the best way. I think the beauty and the challenge of working in prostate cancer is there's so many unanswered questions, and there's so many different opinions on what's the right way, but the evidence, is still evolving. So I think, talking to colleagues in primary care, the biggest thing I keep sort of trying to help them understand is what's changed in terms of diagnostic pathway and how that's impacted on a man's risk. Because the balance is shifting, so I think we need to be sort of more on trying to pick it up early and making sure we reduce harm for men.
Brilliant, Sam. Thank you so much for the session today. I hope everyone has found it helpful and informative. Thank you. Really, really appreciate it. And before we go, I just have a few important reminders for everyone who's tuning in today. So first of all, please don't forget to submit your feedback. It helps us to improve future webinars and gives you your access to certificate of attendance. And if you feel that anything's being missed in these, then please do put that in the feedback and we can see how we can incorporate that in future webinars that we do. The second thing is Prostate Cancer UK, as I've mentioned, has launched a new online learning platform for healthcare professionals with updated resources, some latest resources, webinars and modules. So do check out that link and register today and new webinars and things that we have and deliver will be updated on there, so it kind of keeps you up to date with everything going on in the prostate cancer space. You can also keep up to date with all things prostate cancer by signing up to our health professionals e-newsletter. We give all the updates that are happening in this space, so it again can keep you updated and get us a little email into your inbox. The last thing I just wanted to remind you or let you know about is that we have a Prostate Cancer UK peer support service. So Prostate Cancer UK offers a free one-to-one peer support service that connects patients with trained volunteers with lived experience. And we really find that it's a valuable resource for men to feel less isolated when they've been diagnosed. So to learn more, please visit the link shared in the chat. I'm just going to check for any last questions or anything in the chat. So yeah, that link is the Toluna link to provide feedback to us. Thank you so much. We'd really appreciate it. So that kind of takes us to the end today. I hope you've all found it really helpful to hear from Dr. Sam Merriel about prostate cancer. And thank you for coming, and we hope to see you again soon. Thank you.